You are listening to the Journal of Rheumatology's Editor's Picks with Dr. Earl Silverman, Editor-in-Chief.
Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology. Welcome you to the June 2025 edition of Editor's Summary. This month's featured interview is with Doctors Anushka Agrawal, Maha L. and Rohit Agrawal discussing their article titled Role of CD19 Chimeric Antigen Receptor T-cell Therapy in Idiopathic Inflammatory Myopathies. So could you please give me, just for the audience, a little background on the rationale for the use of a chimeric T-cell receptor antigen therapy or CAR T-cell therapy in idiopathic myopathies?
Sure. Maha or Anushka, do you want to chime in
Yes,
first?
sure. I can get this question. So the chimeric antigen receptor or CAR T-cell therapy is a groundbreaking immunotherapeutic approach initially developed for hematological malignancies. It involved genetically modifying patient T-cell to express a receptor that targets specific antigen, more commonly CD19 on the B-cell. Upon reinfusion, these engineered T-cells recognize and eliminate target cells with high precision. The first successful use of the CD19 therapy in hematologic malignancy was reported in 2010 by Dr. Carol June and colleagues from University of Pennsylvania, who treated patients with refractory chronic lymphocytic leukemia, and the dramatic response observed in these early trials led to rapidly advances in the CAR T-cell development and ultimately FDA approval in 2017 for the acute lymphoblastic leukemia and other B-cell malignancies. The rationale for CAR T-cell therapy stems from its ability to achieve deeper and longer-lasting B-cell depletion compared to the traditional therapy we use, like rituximab. CD19 is broadly expressed throughout the B-cell development, including plasmablasts and short-lived plasma cell, making it more comprehensive target while also offering a long-term drug-free remission. However, over the past few years, encouraging case reports have extended its relevance to our autoimmune diseases such as systemic lupus erythematosus and systemic sclerosis, and also to the idiopathic inflammatory myopathies, where B-cell dysfunction and autoantibody production play a key pathogenic role in these diseases.
Thank you. Anybody want to
Wow, that's a very comprehensive answer, Maha. I don't think I have Maha really nicely covered from the background all the way to current, and I think I would just like to emphasize one point which Maha nicely covered: the fact that we are getting immune reset, specifically B cell specific immune reset, which we haven't been able to achieve with the previous drugs like rituximab and even perhaps with newer generation, monoclonal antibodies, is the key aspect that for CAR T therapies in myositis.
I hope you enjoyed listening to part of my interview with the authors of their paper titled Role of CD19 Chimeric Antigen Receptor T-cell Therapy in Idiopathic Inflammatory Myopathies, and we'll listen to the full interview, which is available at our website at www.jroom.org and on our YouTube channel. Now, moving on to the other articles in the June 2025 edition. It is now recognized that patients with rheumatic diseases have an increased risk of developing herpes zoster infections. In their paper titled Healthcare Utilization and Costs of Herpes Zoster Infection in Patients with Rheumatoid Arthritis, a retrospective cohort study, Moavedi, on behalf of the OBRI investigators, used administrative data to identify 15,573 RA patients who had been diagnosed with herpes zoster infection and a similar number of matched controls. The mean age of the cohorts was 65.5 years. The patients with RA and herpes zoster infection had higher total healthcare costs at each year over a 10-year period as compared to RA patients without herpes zoster infection and to patients with herpes zoster infection without RA. Physician billing and inpatient hospital costs were the largest drivers of costs for all cohorts. These results suggest that there is cost utility in the use of herpes zoster vaccination in patients with RA. Keeping with the RA theme, the next paper is titled Sex Differences in Rheumatoid Arthritis, New Insights from Clinical and Patient-Reported Outcome Perspectives, and by Koch and colleagues. In this treat-to-target study, the authors found that female patients had a higher DAS-44 over time as compared to males, and that female patients had more switches in their biologic therapy. However, there were no differences between the sexes in radiographic progression or sustained DMARD-free remission. The only significant difference between the sexes regarding the PROs that they measured was in the functional ability. In order to help address the issue of the potential for increasing SI joint abnormalities with increasing age, Weber and colleagues undertook their study titled Effective Age on Active and Structural Magnetic Resonance Imaging in Sacroiliac Joints of Healthy Individuals and Patients with Nonspecific Back Pain. They found that the SI joint MRI data from healthy individuals and individuals in nonspecific back pain controls did not show a progressive increase in structural lesions with increasing age categories. This suggests that MRI cutoffs for structural lesions consistent with axial spondyloarthropathy discriminated equally well between axial, SPA, and nonspecific back pain across all age categories. In an accompanying editorial titled Revisiting Magnetic Resonant Imaging Structural Lesions in the Sacroiliac Joints, Dr. Dennis Podubny from the University of Toronto Health Network, University of Toronto, Canada, addresses some of the issues that were not covered in the paper by Weber et al., but does agree with the conclusion that the current guidelines for MRI use as a diagnostic and classification tool for axial SPA are both reliable and robust. We now turn to the use of Secukinumab for the treatment of patients with axial spondyloarthritis, Axial SPA, in a paper by Pons and colleagues titled Predictors of Secukinumab Treatment, Response, and Continuation in Axial Spondyloarthritis, Results from the EuroSpA Research Collaboration Network. The authors examined 1,174 patients with axial SPA from 11 European registries who had initiated Secukinumab treatment in routine care, and they found that a higher baseline PGA, non-concurrent smoking, lack of prior exposure to biologics or traditional synthetic DMARDs, a lower HAC, and a lower BASDI score were associated with a higher chance of achieving both an ASDAS-CRP low disease activity score and a BASDI low disease activity score at 6 months. Overall, they found that 12 baseline features, which included clinical, patient-reported and lifestyle factors were associated with low disease activity at either 6 months and or remaining on treatment at 12 months. In addition to inflammatory back pain, patients with psoriatic arthritis or PSA can also experience mechanical back pain. Haruf and colleagues in their paper, Degenerative Disc Disease in Young Adults with Psoriatic Arthritis, explored this issue of back pain from degenerative disc disease in 814 patients with PSA who are under the age of 50 years and found that 33.8% had evidence of degenerative disc disease on plain radiographs of the spine. The factors associated with the development of degenerative disc disease were older age, male sex, concomitant diabetes mellitus, and inflammatory back pain. The radiographic findings could be asymptomatic, suggesting that the presence of inflammatory back pain did not distinguish axial involvement in PSA from degenerative disc disease in this same group of patients. Keeping with PSA, the next study is by Wang and colleagues and is titled Risk of Mortality of People with Psoriasis and Psoriatic Arthritis in Taiwan, a nationwide cohort study. The authors use the nationwide population-based insurance claim data sets in Taiwan from 2010 to 2018 and found 180,642 incident cases of psoriatic disease, that is, psoriasis and PSA taken together. They found a higher risk of mortality as compared to controls with a hazard ratio of 1.020 after propensity score matching for comorbidities and age. When they looked individually at the risk of mortality, they found it was higher in patients with psoriasis, but not in patients with PSA as compared to controls. There was a trend for higher mortality in patients exposed to biologic therapies. It has been suggested that patients with systemic sclerosis may have received inconsistent quality care, including inadequate screening and monitoring of their disease. In their study titled Improving Systemic Sclerosis Quality of Care, Aboabat and colleagues undertook a study at 4 academic systemic sclerosis clinics to evaluate the uptake of baseline screening, follow-up monitoring, and treatment quality indicators. They then undertook planned to act cycles. They found that the average completion rate of baseline quality indicators increased from 48% to 83% over 8 months after 3 planned to do study act cycles. Monitoring and treatment QI completion improved from 41% to 77%. Similarly, all other measures, such as baseline spirometry and DLCO rates, documented weekly BP self-assessment counseling, referrals to hand motion exercise programs, baseline CK measurement rates, and oxygen saturation documentation rose following the Plan to Study Act cycles. Importantly, the stakeholders reported high satisfaction with minimal additional time per patient, which suggested that this process was feasible. Type 1 interferons have been identified as potentially important markers of disease activity in multiple systemic rheumatic diseases, including juvenile dermatomyositis, or JDM. The study by McMahon and colleagues, titled Correlation Between Interferon Response Gene Score and Disease Activity in Juvenile Dermatomyositis, serially studied the correlation of interferon response gene score and disease activity in 43 patients with JDM, of which 18 were initially studied prior to treatment. They found that there was a significant correlation between the interferon response gene scores and disease activity, which persisted over time, suggesting that this may be a biomarker in patients with JDM. An accompanying editorial titled Interference Response Gene Score in Juvenile Dermatomyositis, Dr. Hannah Kim from the National Institutes of Health, Bethesda, USA, reviews the importance of the interferon pathway in JDM and suggests that further study of this pathway may lead to better personalized treatment for patients with JDM. There is one research letter titled, How Should We Count the Toe Joints in the 66/68 Joint Count in Psoriatic Arthritis? Results of an international survey by DeMarco and colleagues. They conducted an online survey to determine clinical practice worldwide and found that there was no consensus on this issue, but that it is important to standardize the joint evaluation of toes, particularly in clinical trials. This month's article in Panorama 360 Degrees of Rheumatology is titled Enhancing Genetic Studies on Rheumatic Diseases in Latin America, the IRG-RD Initiative. There are two images in rheumatology this month. First is titled IgG4-related arterial disease, an unusual cause of aortitis, while the other is titled Uncommon Clinical and Radiographic Presentation of Monosodium Urate Crystal Deposition in Parotid Glands. This month, we published one case report titled Concurrent IgG4-Related Disease and Giant Cell Arteritis. We also published the abstracts from the 16th International Congress on Systemic Lupus Erythematosus, which was held in Toronto from May the 21st to the 24th. The abstracts include exciting clinical advances, new therapeutic studies, and studies in the pathogenesis of SLE, including biomarkers. All of which these are available online and will be in the print supplement to follow. I want to thank you for listening to this podcast and encourage you to read all the articles which may be of interest to you in the June 2025 edition of the Journal of Rheumatology. The articles are available in either the print or online edition of the journal the latter of which is available at www.jroom.org. I encourage you to watch my interview with the authors of the highlighted article of this month, but also previous months if you missed them. They are all available for viewing at our website and on our YouTube channel. If you have any comments or questions on any of the articles published in the Journal of Rheumatology, please send them to manuscripts@jroom.com. Please join me next month for the July 2025 edition of Editor's Summary, and I want to thank you for listening.